Good morning, everyone. Welcome to Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, and we are discussing this amazing series on NEET SS previous year's topics. So today we are discussing the important topic of Today we will discuss summary of primary renal diseases that manifest as acute glomerulonephritis. Basically, we will discuss the differential diagnosis of acute glomerulonephritis and how we will proceed with these diagnoses. First of these is very important, PSGN. We all are familiar, post-streptococcal glomerulonephritis. Second is IgA nephropathy. Third is good pasture syndrome, and fourth one is idiopathic rapidly progressive glomerulonephritis. So these are four entities which are most commonly observed in pediatric age group and present as acute glomerulonephritis. So the first thing first, what is the age and sex criteria? So PSGN can occur in all ages. IgA nephropathy is 10 to 35 years, good pasture syndrome 50 to 30 year, and RPGN in adults. Okay, so what are the ratio? The ratio is 2 ratio 1 male, 2 ratio 1 male, 6 ratio 1, 2 ratio 1. So this ratio is more. So from this age and sex criteria, you can see from all ages, what are all ages entity are PSGN and RPGN. Next, acute nephritic syndrome. The picture of acute nephritic syndrome seen in almost all of these like PSG 90%, IG nephropathy, good passer syndrome, and 90% in RPGN. So acute nephritic syndrome is the hallmark of all these entity. Next, asymptomatic hematuria. So, just remember, asymptomatic hematuria is mostly seen in IgA nephropathy. So, this is one of the hallmark feature of IgA nephropathy. In other conditions, it is rare. Nephrotic syndrome. Okay, we are talking about differential diagnosis of nephrotic syndrome, but in some cases, nephrotic syndrome can be found in 5 to 10% of PSGN and 10 to 20% of RPGN. It is rare in IgA nephropathy and good pasture syndrome. So, nephrotic syndrome per se is most commonly seen in RPGN and in PSGN 5 to 10%. Hypertension. Is hypertension associated? Yes. PSGN has 60% occurrence of hypertension, the most in these group of diseases. IgA nephropathy 30 to 50% and RPGN 25%. Acute renal failure 50% in PSGN, which is transient, but most common association of renal failure is with RPGN. Others like latent period of 1 to 3 weeks, we will think of PSGN. If something follows viral syndrome of 2-3 days duration, we will think of IgA nephropathy. If associated pulmonary hemorrhage and iron deficiency anemia is there, we will think of good pasture syndrome. Okay, lab finding we'll discuss in PSGN ASO will be increased in 70% cases, positive streptozyme in 95% cases, complement C3 to C9 are decreased, C1 and C4 are normal. So this profile of PSGN is very much important, just pay attention. ASO is increased in only 70% cases, positive streptozyme increase in 95%, C3 to C9 complements are reduced, but C1 to C4 are normal. IgA nephropathy, serum Ig elevation seen in only 50% of patients, not 100%, though it is a disease of Ig, but Ig in dermal capillaries is seen, in serum it is seen in only 50% cases. With good pasture syndrome, positive anti-GBM antibodies are seen, and in RPGN, positive ANCA in some. Is there any HLA association? Immunogenetics? Yes. Post PSGN, HLA-B12, D, E, and 9. And IgA nephropathy, HLA-35, DR4. Good pasture, HLA-DR2. Okay, we will do renal pathology. Now we are entering into pathology of these diseases. On light microscopy, PSGN shows diffuse proliferation, IG nephropathy focal proliferation, good pasture focal to diffuse proliferation, and precentric glomerulonephritis seen in RPGN. This is very important question. Precentric glomerulonephritis is seen in which disease? That is RPGN. If we do immunofluorescence, IgG and C3 deposits are seen in PSGN. Diffuse mesenchymal IgA deposition seen in IgA nephropathy, as the name suggests. Good pasture syndrome, linear IgG and C3 deposit similar to that PSGN, and RPGN, no immune deposits are seen. If we proceed to electron microscopy, subepithelial hump, again this is very important, subepithelial humps are seen in PSGN, mesenchymal deposits are seen in IgA nephropathy, and in good pasture and RPGN no deposits are seen. So, what is the prognosis? Prognosis is good in PSGN. More than 95% cases resolve spontaneously. 5% of RPGN are slowly progressive. Similarly, IG is also slowly progressive, and uh, good pasture and RPGN are stabilized, and if the treatments get starts early, they are tend to improve. What is the treatment for PSGN? Monitor for oliguria, hypertension, and treat appropriately, basically symptomatic management. IgA nephropathy, it is generally uncertain. Some drugs can be tried like steroid, ACE inhibitor, and sparsentan used in adults. Good pasture syndrome, plasma exchange, and steroid cyclophosphamide, and RPGN steroid pulse therapy. Okay, so far we discussed the important consideration of these four entities, which are PSGN, IgA nephropathy, good pasture syndrome, and RPGN. So just remember the important salient point of this disease. For your revision purpose, I will revise this disease under 30 seconds. For PSGN, it's seen in all ages. Nephrotic syndrome association 90%, nephrotic syndrome 5 to 10%, hypertension is 60% association, acute renal failure in 50%, but that is transient. ASO will be increased in more than 70% of patients, but positive streptococcal is seen in 95%. Complement will be reduced from C3 to C9, but complement C1 and C4 will be normal. Light microscopy will be seen as diffuse proliferation and IgG C3 deposition on immunofluorescence. Electron microscopy will show subepithelial hump, and prognosis is generally good. 95% cases resolve spontaneously. Treatment is conservative management. On the other hand, IgA nephropathy, as we can see, this seen in 10 to 35 years of age, 2:1 male ratio, nephritic and asymptomatic hematuria seen in half of the population, hypertension also seen in half of population, serum IgA is elevated in only 50% of cases, diffuse mesenchymal deposition is seen, and uh, the drugs are uncertain. We can use ACE inhibitors, steroids, etc. Good pasture syndrome, again, it is disease of 50 to 30 years, 6:1 male ratio. It is not associated generally with nephrotic, asymptomatic hematuria, and hypertension. To correct with, it is associated with nephrotic syndrome definitely, but asymptomatic hematuria, nephrotic syndrome, and hypertension are less found. Okay, so positive anti-GBM antibodies and linear IgG and C3 deposition are seen. Idiopathic rapidly progressive RPGN. So this is seen actually nephrotic syndrome 10 to 20%, positive ANCA in some, no immune deposition on immunofluorescence. Okay, With this basic knowledge, we will move towards clinical features of acute glomerulonephritis. Keeping these disease in mind, we will discuss these. Okay, so if we will see serum complement, which is C3 and CH50. We will mainly focus on C3 and CH50 if they are decreased. In which conditions these complements can be decreased? Just remember, first we have seen in renal disease, acute post-infectious PSGN seen in 90% cases. Other glomerulonephritis, yes, membranoproliferative glomerulonephritis seen type 1, seen in 50 to 80%. So MPGN type 1 in 50 to 80% cases and PSGN 90% of cases these complements are decreased. Are there any other systemic disease which are associated with decreased complement? Yes, they are lupus nephritis, SABE, subacute bacterial endocarditis, shunt nephritis, essential mixed cryoglobulinemia, and visceral abscess. Just remember all these causes, they are very important, which in them complements are decreased. If normal serum complements are there, is there any renal disease which associated with normal serum complement? Yes, the remaining disease, IgA nephropathy, rapidly progressive crescentic GN, type 1 anti-GBM, type 2 immune complex CGN, type 3 posi-immune CGN, and post-infectious, which is non-streptococcal. In these renal conditions, complement level are normal. In systemic disease, polyarteritis nodosa, hypersensitivity vasculitis, IG vasculitis, Goodpasture syndrome, in these conditions, these are normal. Okay, if complement levels are decreased, how we will proceed further? We will see, is there any serological evidence of antecedent streptococcal infection? How we will examine this? We will do ASO titer, anti-DNase B, and streptozyme. Okay, so if we establish this, if these are positive and return of low serum C3 complement to normal by 6 to 8 weeks, if these are positive, serological evidence are there, and after 6 to 8 weeks these complements gets normal, then diagnosis will be acute post-streptococcal glomerulonephritis. Okay, if these serological evidence are negative or failure of low serum C3 complement to return to normal by 6 to 8 weeks, okay, then the diagnosis will be like lupus nephritis, means the other conditions of C3 decrease complement decrease like lupus nephritis, essential mixed cryoglobulinemia, shunt nephritis, visceral abscess, bacterial endocarditis, and post-infectious GN non-streptococcal. So this the flow chart nicely summarized the causes and clinical features of acute glomerulonephritis on the basis of complement decrease and core complement normal. So, and if complement get decreased, so we will see the recent evidence of streptococcal infection by ASO titer, anti-DNase B, and streptozyme test. If these are positive and complements are normal within 6 to 8 weeks, the diagnosis will be post-streptococcal glomerulonephritis. If these complements are not normalizing by 6 to 8 weeks or no evidence of serologic evidence, we will see other differential diagnosis. Okay, now what we'll see this is immunoglobulin complement mediated glomerulonephritis. Okay, so we will see. Okay, uh, this is actually very exhaustive looking flowchart, but we will go step by step. Okay, if we happen to see linear glomerulobasement immunoglobulin immunofluorescence staining, okay, so this is anti-GBM disease. Okay, anti-glomerulobasement disease. Two differential diagnosis of this condition is anti-GBM glomerulonephritis, that is the other thing, and Goodpasture syndrome. So in Goodpasture syndrome, the lung hemorrhage will be there, otherwise it will be same at anti-GBM disease. So these are two differential diagnoses. Okay. Then again, if granular immunofluorescence staining for C3 or little or no immunoglobulin, so this is actually C3, only C3 deposition. So C3 glomerulopathy will be seen. The only two differential diagnoses of C3 glomerulopathy are DDD, dense deposit disease, and C3 glomerulonephritis. If dense deposits are found, then it is okay, it is dense deposit disease. Okay, next, if paucity of immunofluorescence staining for immunoglobulin or complement, so this is ANCA disease. ANCA means anti-neutrophilic cytoplasmic autoantibodies. Okay, how we will differentiate them? We'll see if no systemic vasculitis, this is ANCA glomerulonephritis. If vasculitis with no granuloma or asthma, it is NPA. If vasculitis with granuloma with no asthma, it is GPA. If vasculitis with granuloma and asthma, it is EGPA. So this is very important. Okay. So what we able to see in this condition, microscopic polyangiitis, granulomatous with polyangiitis, and eosinophilic polyangiitis. Okay, so in these conditions, what you can see, only vasculitis is there, vasculitis plus granuloma, vasculitis plus granuloma plus asthma. So how we will differentiate them? Okay, if immune complex deposition is seen, so how we will proceed? If immune deposition is dominant Ig and no vasculitis, this is Ig nephropathy. If dominant Ig and vasculitis, this is Ig vasculitis. Systemic lupus erythematosus, it is lupus nephritis. Acute streptococcal staph infection evidence PSGN. Thickened capillaries in hypercellularity, this immune complex. Thick capillaries, no hypercellularity, membranous glomerulonephritis. Less than around 20 nanometer fibrils, this is fibrillary glomerulonephritis. Other features like immune complex GN. Okay, so here are some secondary causes of MPGN associated with infection like hepatitis B, C, visceral abscess, shunt nephritis, associated with rheumatological disease like SLE, scleroderma, Sjogren, sarcoidosis, associated with malignancy, carcinoma, lymphoma, leukemia, associated with an inherited disorder, alpha-1 antitrypsin deficiency, complement deficiency. So this was in brief with we are just discussed the important concepts in differential diagnosis or approach to glomerulonephritis in the form of the major disease and immune complex deposition, how they are differ from each other. Euconium Ileus will discuss some another topic of this amazing series. Till then, do share, like, and